We'll start at 4:30, no?
Oh, it's live now, but
Okay, fine, no problem. We'll start at 4:30, no?
oh, it's live now, but
Okay, fine, no problem. Good evening, ma'am.
Good evening, Leela madam.
Hello, ma'am.
मैडम आप म्यूट हैं।
हाँ मैं कर रही
हो गए
आप ठीक हो?
हाँ हाँ
कैसी है
मैम अच्छी हूँ।
कैसी और मम्मी
को भी बोला है देखने को।
आए क्या? मैडम ने ज्वाइन किया है क्या?
बोल के आती हूँ मैं।
हाँ हाँ
करवा लो, मजा आ जाएगा।
हाँ बिल्कुल।
नेहा डॉक्टर शेफाली और डॉक्टर सरिता को बता दिया था।
कॉल कर दिया था, लेकिन शेफाली मैम की एक लेबर वेटिंग थी तो शी सेड कि थोड़ा सा लेट ज्वाइन करेंगी।
हाँ हाँ
गुड इवनिंग पूर्णिमा मैम।
ये स्वरूप आ गई।
अच्छा, गुड इवनिंग बंडी मैडम, प्रणाम।
कहाँ गए स्वरूप?
गुड इवनिंग मैम।
बंडी मैडम प्रणाम, वेलकम रतलाम सोसाइटी में। पूर्णिमा मैडम गुड इवनिंग। दीदी ये तो बहुत अच्छा किया, मैडम को भी ज्वाइन करवा दिया।
मुझे तो दिख ही नहीं रही।
हाँ चालू है मैडम उनका।
नहीं, मुझे नहीं दिख रही।
नेहा बीच में पिक्चर्स लेना।
तो कहा गया पिक्चर लेना तो कौन सा?
स्टार्ट करें, 4:30 हो गया। अनुपमा दीदी
यस करो।
हाँ नेहा
I hope I'm audible and visible both.
यस यस
Good evening
आशा मैडम एंड बोथ ऑफ यू आर विजिबल।
Joint account. Good evening, everyone. On behalf of Islam ROGS and Gynae Society, I
Please be loud. Neha, please be loud.
is it better, ma'am?
हाँ फिर भी कम है अभी.
Good evening, everyone.
हाँ ठीक है.
On behalf of Islam ROGS and Gynae Society, I, Dr. Neha Saraf, the Secretary of Society, take the privilege and the honor of welcoming you all for this webinar on vaccination in pregnancy. I would request our President, Dr. Manisha Maheshwari ma'am, to come and join us for her welcome note.
Thank you, Dr. Neha. Good evening, all. I invite and welcome our guest faculty from Indore, Professor Dr. Anupama Dave, Madam, to deliver talk on vaccination during pregnancy. It is a practical topic of use in our daily practice. I welcome Dr. Asha Saraf, Madam, Senior Member of ROGS, to kindly chair this session. I also welcome all the members of ROGS who have joined us for this meeting. It is my privilege to introduce Dr. Asha Saraf, Madam. She is Senior Consultant OBGYN at Ankur Hospital, Ratlam. She is past President ROGS and past Honorary Consultant Divisional Railway Hospital, Ratlam. Welcome, Madam.
Thank you.
Now I hand over the floor to Dr. Neha for further proceeding. Dr. Neha.
I would request our chairperson, Dr. Asha Saraf ma'am, to please introduce and invite our guest speaker for her talk.
Good evening, everyone. It's my privilege to introduce Anupama Dave, Dr. Anupama Dave. She is a professor of MGM Medical College. I think now she is working in Superintendent MTH Covid Hospital, Indore. Everybody, I think so, at least Ratlam a member knows her very well because she was actively participate in our Ampong, I think October 2018. She is very actively participate and as a chairperson, as a speaker also. Or now she is very helping and very kind of nature. So I will just say she is the present secretary of ISOPAB Indore chapter, professor, past secretary of IMS Indore chapter, organizing secretary in INSCON 2015 and BRACECON Indore, past president Indore, Foxy 2010 to 2011, active member of Indore Society last 15 years. Awards recipient of Foxy, some international traveling fellowship 2016, received ICOG Foreign Travel Award 2014, winner of prestigious Foxy Korean Award 2000 for research winner Dr. C.S. Don Best Award. Uh, she is a winner prestigious Foxy Korean Award. Then Amicon 2012 Varanasi. Winner of Dr. Dr. Amendu Nath. Okay. Dr. Amendu Nath. Amendra Nath Don Award AICOG 2015 Chennai. Invited faculty AICOG since last year's master trainer and nodal officer for Foxy EMSI training. Master training for IPS CAC training. Publication 40 in national and international journals. In special interest in high risk pregnancy and DVH. So today the topic is very important topic. It's very useful topic, day to day practice. I invite Dr. Anupama there. Please.
Thank you, Madam, for your very kind introduction. Good afternoon, everybody. Respected Chairperson, Saraf Madam, dear colleagues, at the outset, I would like to thank President and Secretary of Ratlam Obs and Gynae Society for giving me the opportunity to speak on this important topic. But before that, I would like to give special thanks to Dr. Manisha Maheshwari, who is the president and whom I know since my PG days as a hardworking, sincere, intelligent, and a dynamic person. Her these qualities are now an asset to the Ratlam Obs and Gynae Society, and since few months we are seeing so many webinars on electronic platform which have been conducted under her leadership. And also, I congratulate the Ratlam Society as a whole for all their successful endeavors. Now
Thank
to
you, ma'am.
start my topic.
Is there a problem in sharing this?
No, it's okay now. It took time opening, but now it's all right. So the topic which I'm going to speak on is vaccination in pregnancy. One of the greatest triumphs in immunology is the development of vaccines against certain infectious agents. And you would all agree that this is something very important, especially in this COVID era when we are waiting eagerly for the vaccine against COVID. Vaccination, therefore, is the most successful, cost-effective intervention to the public, which has led to eradication.
मैडम आपकी स्लाइड्स विजिबल नहीं है, एक खाली ट्रायंगल दिख रहा है।
मेरी स्क्रीन पे तो विजिबल है।
आप सबकी स्क्रीन पे
नहीं है।
नहीं मैम, विजिबल नहीं है।
फ्रीज हो गया, कुछ हैंग हो गया।
पेन
नहीं है मैम।
तो या तो एक बार आप स्टॉप शेयर करके फिर से एक बार शेयर करने का ट्राई करिए।
वापस शेयर करें।
हाँ जी। हाँ जी, नाउ यू आर विजिबल।
हाँ ठीक है दीदी।
So, the introduction of vaccination is one of the most important triumphs of immunology, and it is successful and cost-effective public health intervention. It has led to eradication of many diseases like smallpox, control of polio and whooping cough as well. Now, if we think of maternal vaccination, it protects not only the mother, but the fetus as well. Infant passive protection is provided by the vaccine against infectious agents and those which are acquired independently after birth. Ideally, all immunizations should be given before conception, but some vaccinations may need to be given in pregnancy, and this is the main aim of the presentation. Now, let us understand the basics before we go into the details. Whenever an antigen invades the human body, there are defense mechanisms, and these lead to immunity. Immunity, which is of two types: innate immunity, with which we are born with. It is less specialized, less powerful, first line of defense. It is antigen non-specific, and it has no memory. This point we should keep in mind. Now, the various components of innate immunity are the epithelial barriers, phagocytes, neutrophils, monocytes, etc. But adaptive immunity or the acquired immunity is evolved later. It is more specialized, more powerful, it has high specificity, it even has memory, and the components include lymphocytes, T and B cells, and their products, antibodies, and cytokines. So it is this adaptive immunity which is the basic principle of our vaccines. Vaccine, if you want to define it, is the biological preparation that improves immunity to disease, and the whole process in which we stimulate protective adaptive response against a microbe by exposure to non-pathogenic forms or components of microbes is known as vaccination. So, as I had already said, they work by inducing active immunity and by providing memory and generate antibodies against the pathogen. Now, if we talk about pregnancy and vaccination, the immunogenicity and placental transfer, healthy pregnant women can mount a similar immune response to antigens, same as a healthy non-pregnant woman. However, transplacental passage of antibodies depends on maternal concentration. The type of antibody, IgG antibody, is only passed through the placenta. Its subtype, IG1, is passed, and then it also depends on the gestational age. Fetal immunoglobulin concentration is much lower compared to maternal concentration in first half of pregnancy. Then it increases to 50% maternal levels at 28 to 30 weeks, and then it equals maternal levels at 36 weeks. And then at term, sometimes the antibody level in the baby is more than that of the mother. Maternal IgG levels reach their peak only after 4 weeks after immunization. So this period is to be taken into account at the time of vaccination. Gestational age and maternal immunization is important when passive neonatal immunity is the goal. The ideal timing of vaccination, however, should be early third trimester to achieve maximum maternal levels and maximum antibody transfer to the baby. The types of vaccines, there are 3 types of vaccines: live vaccines, killed vaccines, and there are some other types which include purified macromolecules. The live vaccines, they are not live viruses, but they are attenuated. These microbes have been treated to abolish their infectivity and pathogenicity, but still they have their antigen potential. There is a possibility that this antigen may be incorporated in the host genome, and therefore it may again become virulent. And this is the reason why these live vaccines have a potential to infect the fetus. So live vaccines are not given in pregnancy. If you talk about killed vaccines, they are inactivated, but a large amount of antigen is required. And these preparations are often injected. The purified macromolecules are of 3 types: inactivated toxins. So some antigens are in the form of toxins like diphtheria toxoid and tetanus toxoid. So they act as antigens. Inactivated toxins act as antigens and are used in the vaccine preparation. Some vaccines like Haemophilus influenzae, Neisseria, and Streptococcus pneumoniae, they are carbohydrate vaccines and they need to be conjugated to a carrier protein. So that's why they are known as conjugate vaccines. Then some vaccines utilize only a part of the antigen, that is like a Dane particle from HBsAg. So they are known as subunit vaccines. These were the types. Now to highlight the difference between live and killed vaccines. Live vaccines generally require single booster, less stable, both humoral and cellular mediated immunity is there. May revert to virulent form, as I had already said, only a small dose is required given by natural route, and live vaccines are always more potent. But they require more, killed vaccines require more amount and they require boosters. Only humoral immunity is induced, does not revert to virulent form. It is given in higher doses given by alternative routes like intramuscular route, and they are less potent. Now, clinical classification of vaccines which are used in pregnancy. They can be highlighted just like a traffic symbol. Red ones, the ones which are contraindicated; yellow ones, which can be used in specific situations; and green ones, which need to be given, which have to be given. So the contraindicated ones are BCG, measles, mumps, rubella, varicella, smallpox is vaccinia, and HPV. Now the ones which are indicated are inactivated influenza vaccine, vaccine against pertussis, diphtheria, tetanus, inactivated polio. In certain situations, when the benefit outweighs the risk, some vaccines have to be given, and they are hepatitis A and B, meningococcal, pneumococcal, typhoid, rabies, and yellow fever. It is said prevention is better than cure. So we must minimize the risk of infection itself to these pregnant women by avoiding travel to high-risk areas, by assuring that the household members are immunized according to standard immunization schedules, because even household members may act as potent infectants to the pregnant women. And of course, in all situations, maintaining a good hygiene practices is essential: hand washing, consuming clean water, cooking food adequately. Ideally, all vaccines should be given preconceptional, especially those conditions in which there are bad adverse outcomes of infections like measles, mumps, and rubella. There are adverse pregnancy outcomes and increased morbidity if it occurs in pregnancy. So, ensuring immunity against MMR and varicella, which is chickenpox, is important. They should be immunized prior to pregnancy because vaccines are contraindicated in pregnancies. Before giving any live vaccine to a woman in childbearing age, we should see that we should confirm that the woman is not pregnant or is not likely to be pregnant in next 4 weeks. And for this, adequate counseling is essential. The fetal risks of any vaccine should be counseled with the woman before giving it. Routine pregnancy testing, however, before vaccination is not recommended. You can rule out pregnancy by asking detailed history, and a checklist is there for that purpose. We must avoid pregnancy for at least 28 days following each dose of live vaccine like varicella. Varicella, according to the manufacturer, they've advised 3 months, but according to various guidelines by different societies, they've recommended 1 month. Adverse outcomes in women who become pregnant soon after receiving these vaccines have not been established. So termination is an individualized approach. So whether to terminate or not, it depends on the situation, and adequate counseling of the women is essential for that. So there are no proved termination rules for those women who receive live vaccines and then they become pregnant. Most important is MMR, which is a live vaccine. Documenting immunity to rubella is a routine component of preconceptional care, because we know that as such, rubella also causes some adverse effects on the fetus as well. MMR vaccine is a live attenuated vaccine. So it is given to women who are not pregnant and who have not substantial immunity to rubella. The evidence of immunity, how to find out whether the woman is immune or not, is on the basis of documented age appropriate completion of MMR vaccination. At least 1 dose of live rubella containing vaccine should be given in that lifetime, or a lab evidence of immunity, or a lab confirmation of disease. So either of these is there, then we do not need to give her a rubella vaccine again. The test determining rubella immunity is, of course, the Ig titer, as for all infections. The IgM titer only is taken in those cases in which there's a suspicion of recent or acute infection. Once rubella immunity is documented, repeat rubella serology is unnecessary in subsequent pregnancies. So once she has a high level of IgG, then we can forget about it. Measles also, it becomes more morbid if it occurs in pregnancy. And so we have this vaccine which is together along with mumps and rubella. So MMR vaccine is for measles also. Now about chickenpox. Varicella zoster in pregnancy has severe maternal complications. There are chances of congenital varicella syndrome, and even neonatal varicella zoster infection has been seen. Non-pregnant women without evidence of immunity and who are not likely to become pregnant in the next month are ideal candidates for this vaccination. According to ACOG and RCOG guidelines, avoid pregnancy for 1 month after receiving varicella vaccine. So those were the pre-conceptional vaccinations. Now coming to the routine vaccination, the prenatal immunizations which are required. The first thing which usually comes in our mind is tetanus. We need to vaccinate the woman against tetanus. But why? Neonatal tetanus is rare in countries where universal immunization of children and adults with tetanus toxoid is a routine. It has been almost eradicated in many affluent countries. The estimated vaccine effectiveness is about 90%. Developing countries, it is one of the leading causes of neonatal tetanus, and we know all the causes: unclean cord cutting, unhygienic deliveries, and lack of maternal tetanus immunization. It is a preventable disease and can be eliminated if tetanus toxoid is given to pregnant women, and promotion of aseptic obstetric practices and postnatal umbilical cord care is an effective method of reducing neonatal tetanus. Now, we routinely give the tetanus vaccine to pregnant women. But what is the ideal situation? The Tdap vaccine is now routinely recommended by all societies for vaccination in pregnancy. This includes tetanus, diphtheria, pertussis, and this is to be given to all pregnant women in the 7th month of pregnancy. This is a routine for our country. But these are the various guidelines which I've taken from RCOG and ACOG, and we must to understand it fully, we must go through these guidelines. Pregnant women who received 3 full doses of TD vaccine can receive a single dose of Tdap, ideally during the early part of pregnancy, early part of 27 to 36 or to 36 weeks gestational range. So those who have received 3 full doses need only a single dose of Tdap. Tdap is indicated in each pregnancy, even if the woman has had a previous pertussis infection or vaccination, or even if the consecutive pregnancy occurs within 12 months. Now, for those women who are not vaccinated, women for whom 10 years has elapsed since the last TD booster dose, the Tdap serves as a booster vaccination against tetanus and diphtheria as well. So they should have received at least 2 doses previously or 3 doses previously and a gap of 10 years. If the Tdap cannot be given, TD booster during pregnancy is recommended. So instead of giving tetanus alone, we can give diphtheria along with tetanus. Also, if more than 10 years have elapsed and it is required for wound management, if she's had some cuts which require management. Booster protection for wound management is advised when more than 5 years have elapsed and the wound is not clean or is a minor wound. Tdap, however, can be given earlier than 27 to 36 weeks at any stage if a woman lives in an area where there's pertussis epidemic or requires tetanus for wound management. So it is not necessary that it is to be given at 7 weeks itself. If it is required earlier, it can be given before 27 weeks also. If it is given early in a pregnancy, it should not be repeated later in pregnancy. So a single dose of Tdap is required for all women. If Tdap is not given in pregnancy, it should be administered immediately after delivery in those women who have not had previously received Tdap. This can provide protection to the infant indirectly, or if breastfeeding post-vaccination. Vaccination of household contacts is also essential. We must also ensure that women or household workers who take care of our babies have been vaccinated adequately with pertussis vaccine and diphtheria vaccine. Inactivated polio vaccine is also offered along with Tdap in UK at 28 to 32 weeks. But here in our country, routinely polio vaccination is being given and mostly it has mostly been eradicated, so we do not require this. Now, the rationale behind pertussis. The chances of and prevalence of pertussis are constantly increasing. Immunity after vaccination or even after having the disease wanes over time. Adults who develop pertussis can transmit the disease to susceptible infants in the household, which is a concern because infants who are less than 3 months of age are at the highest risk of morbidity and mortality from this disease. Various observational studies suggest that decreased risk of infant pertussis with maternal vaccination during pregnancy. However, vaccination too early or too late in pregnancy may result in suboptimal protection. Now, besides Tdap, the next vaccine which should be given to pregnant women is inactivated influenza vaccine. All women pregnant during the influenza season should receive it as soon as it becomes available and before the onset of influenza activity in their community. So before flu starts, this vaccine should be given. Vaccination after the onset of influenza activity is still beneficial as long as it is circulating. Intramuscular injection is given into the deltoid muscle. Influenza is particularly morbid in pregnant women and even in postpartum women, and results in serious medical and pregnancy complications and even requires hospitalization. Vaccination reduces the risk of these complications and provides passive protection. Inactivated influenza vaccine is safe in pregnancy, postpartum, and even breastfeeding. Multiple studies have evaluated the safety in pregnancy, even being given in H1N1 pandemic, and have not demonstrated any increase of maternal complications or fetal adverse outcomes. So those two vaccines are given in pregnancy. Now, in some special circumstances, some vaccines have to be given. Pre-exposure prophylaxis. Some pregnant women at high risk, those who have comorbidities, occupational risk, or have travel history, high incidence in the area of residence, or have an exposure risk, they require some vaccinations. Women who meet these vaccine recommendations should be immunized because some vaccines are not known to be harmful in pregnancy. And if infection occurs, it could cause more harm. So this risk and benefit ratio should always be evaluated in these circumstances. First is a pneumococcal vaccine. It is recommended for adults. Conditions that in those women in which conditions they have that increase the risk of pneumococcal disease. Ideally, the vaccine should be given prior to conception, but can be given in pregnancy in the second and third trimester. However, there's no information of safety on first trimester vaccination. So these are the indications in which pneumococcal vaccination needs to be given. Immunocompetent persons, but they have CHD or diabetes or chronic lung disease, alcoholism, chronic liver disease. Absence of spleen, functional or anatomic, presence of sickle cell disease, hemoglobinopathy, immunocompromised women who have HIV, chronic renal failure, nephrotic syndrome, etc. So these are the indications of pneumococcal vaccination. Next vaccine is a meningococcal vaccine. There is no evidence that either vaccine, the conjugated or the quadrivalent vaccine, is unsafe. So it is safe. The usual advice is to avoid vaccination unless the mother is at high risk of disease. Indications are functional and anatomical asplenia with immunosuppression, complement deficiency, those who travel to high endemic areas, those who have contact with infected individuals, university students, years of age. It is safe in breastfeeding. There are two types of meningococcal vaccines available. The next is the Haemophilus influenzae vaccination. Inactivated vaccine is recommended in adults who have not received it in childhood as a part of HIB series, that is Haemophilus influenzae type B series, and are at a risk for invasive disease due to certain chronic conditions like sickle cell disease, leukemia, HIV, or splenectomy. So these three vaccines, pneumococcal, meningococcal, and Haemophilus influenzae, are usually given together and in those people who require it. Coming to the next, hepatitis B is a recombinant vaccine that poses no harm. Indications: pregnant women who are completing the immunization series, which has been started before conception, unvaccinated, uninfected pregnant women who are hepatitis B surface antigen negative but are at a risk of acquiring this infection or have high risk characteristics which expose them to hepatitis B infection. These are the two conventional recombinant vaccines which are available. Then hepatitis A. This also can be given to pregnant women. The indications are planned international travel, injection or non-injection substance use, occupational risk, close contact with an international adoptee or a person who is homeless, who might have acquired hepatitis A, a concern for severe outcome from hepatitis A infection, like if the patient has herself chronic liver disease or HIV. If susceptible women are exposed to hepatitis A virus during pregnancy, HIV vaccination and passive immunization with immunoglobulin is required. Yellow fever is not that prevalent in our country, but it is a mosquito-borne viral hemorrhagic fever and it occurs in tropical regions of South America and sub-Saharan Africa, and it has a high case fatality rate. So any pregnant woman who is going to travel to that area would require vaccination with this vaccine. The polio virus is a systemic viral infection. It has varied manifestations ranging from asymptomatic disease to paralysis. In many countries, it has been eradicated, but transmission continues in these countries: Africa, Pakistan, Afghanistan, Nigeria, Somalia, Ethiopia, etc. Pregnant women should avoid travel if possible to these areas, but if travel is not avoidable, they can be vaccinated with the inactivated polio vaccine. Typhoid fever is a systemic febrile illness and caused by contaminated food, water. Asia, Africa, and Latin America, typhoid vaccination is partially protective and recommended for pregnant women traveling to typhoid affected areas. Pregnant women should avoid traveling to these areas, but if it is essential, these are the two types of vaccines which are available. They should be avoided in pregnancy because of the theoretical risk of in utero infection. An alternative inactivated vaccine is also available and that can be used. But in our country, we usually do not vaccinate with typhoid vaccine during pregnancy. Other travel vaccines include inactivated Japanese encephalitis vaccine. Then rabies vaccine post-exposure prophylaxis needs to be given. It is an inactivated vaccine, can be given during pregnancy. If the risk of exposure is substantial, it can be given in pregnancy along with rabies immunoglobulin. Now, in some special circumstances, extenuating circumstances, smallpox and anthrax vaccines can also be given if there is a very high risk of direct exposure to that woman, and in order to prevent infection, they can be given only after consultation with experts. Now, typical vaccinations which should be avoided during pregnancy. And the most important one is HPV, human papilloma virus vaccine. We know that there are 4 types of vaccines: bivalent, quadrivalent, and nonavalent or 9-valent. Administration of any HPV vaccine during pregnancy is not recommended because of lack or limited information about its safety. If a pregnant woman, after initiating the vaccination series, if identified that she's pregnant, further doses should be delayed until after pregnancy. So you should stop it then and there. We should also reassure that woman that the available evidence does not indicate that there is any adverse outcome in pregnancy after vaccination. Now, there are a few studies. A few offsprings have been noted to have congenital anomalies like pyloric stenosis and chyloglossia, congenital hydronephrosis, megacolon, clubfoot, etc. With the quadrivalent HPV vaccine within 30 days of conception. But an expert panel found that these congenital malformations were unrelated to vaccine exposure. So still we do not have enough evidence about it. There is a pregnancy registry which has been established for the quadrivalent vaccine, and same is for bivalent and nonavalent vaccine. And if a woman becomes pregnant while the vaccine, then again, it is an individualized approach. The pros and cons of continuing the pregnancy should be thought of, and then only you should consider for termination. Postpartum vaccination. We do not practice this, but in ideal circumstances, this must be done. 2 vaccines which should be specifically administered to mothers who are not immunized previously before pregnancy or during pregnancy. MMR vaccine and the varicella vaccine. See, these 2 vaccines we cannot give in pregnancy. So if you've identified that she is not immunized against them, we should give them during the breastfeeding period. So it is said an ounce of prevention is worth a pound of cure. Meanwhile, in the 2020 COVID pandemic, the whole world is trying hard to combat this pandemic and is trying to look for a vaccine. Mankind is in a desperate need of this vaccine so that it is effective and so that it prevents many of the lives which are being gone due to this. For pregnant women, it is still a matter of speculation whether a pregnant woman would get this COVID-19 or would require this COVID-19 vaccine or not. So thank you for your kind attention. And I'm happy to solve any queries which come along. Well, I would put this on my YouTube channel, this presentation also on my YouTube channel, but there are many others also which would be of use to you as clinicians. So please do subscribe. Thank you.
Thank you, ma'am. Thank you for the very informative, very the point. Now I request our chairperson, Dr. Asha Saraf ma'am, for her words of wisdom to conclude the topic.
Uh, I think so. Thank you so much, Anupama. You have given us so informative and so informative with every vaccination. So I think so. No need of saying anything about this at all. But still, we are very happy that we came to know about the Tdap vaccines and other vaccines which are not we cannot give in during pregnancy and but we can give in a postpartum like MMR and chicken pox. I think so. Okay, so many everybody came across with the smallpox. Chicken pox is very common, not smallpox, but any so many gynecologists we are pregnancy with the chicken pox, and but they are coming very late with the sports and all these things. They are already exposed it. So my question is, Anupama, should we then it is no need of I think taking the vaccination, no?
Yes, if she's already immunized, she's had this infection, antibodies have developed, then she won't need any vaccination for it.
And second, say the Tdap, you said ki 3 doses of giving tetanus and then we should give the Tdap. Is it like that? Ki 3 doses?
Yes, yes. So now for our country, see, we know that women do receive 2 doses of, like children receive 2 doses of tetanus and diphtheria booster in their childhood. They do not receive the third dose, which is essential at 10 years of age. So for our pregnant women, we have this schedule, immunization schedule that we should give this Tdap. We should give TD, tetanus and diphtheria, at 5 months of gestational age, and then give Tdap at 7 months.
7 months. And only tetanus toxoid is 1 dose,
Only tetanus toxide is not to be given nowadays.
not to be given. That is the main point because the
If you don't have it, if you don't have TD injection, we can give tetanus only, but ideally we should give TD and then give Tdap.
we don't have a TD injection, but we have TDAP injection and we are practicing to give the TDAP. But normally tetanus toxoid every Anganwadi wali with it, they are giving it the pregnancy hai UPT kiya, second month maybe they are giving. So it should I think ideally it should not be given in a first trimester, no. Uh,
It is not given, but previous, government had given previously guidelines that as soon as a pregnant woman comes to the antenatal clinic, you have to give her a tetanus vaccination. So according to that role, they are giving tetanus, but I don't think it causes that much harm because almost all of our women have received tetanus. Many of them have received it in the first trimester. So if they have received 1 dose in first trimester, we can give this Tdap at 7 months.
TDAP is 7 month. Okay. But 2 doses of fitness they have already taken. Then 1 dose of TDAP we can give at the 7 month.
Because now we want diphtheria protection also, and we want protection against pertussis also.
That's right. Oh, that is good. And other thing that other vaccinations that you told about the hepatitis vaccine, it's no use of giving as soon as. But the patients are not coming. That they that says that we are planning for pregnancy or something like that. They always come when we go for a pregnancy profile and it comes to be hepatitis B positive. So they are worried. Madam, vaccine लगा दो ठीक हो जाएंगे. So I think so. Okay, it's not in a generalized people. They
Now
are
vaccination won't work, but then we have to screen the husband. If the
Yeah.
husband is still hepatitis B negative, we have to give the husband vaccine.
We are advising husband also at least family member and you go for a hepatitis B vaccine. At
Yes.
least for the next after the delivery, these people are the safe, and this is very important. I think so. People pregnant, nobody comes for the what things should be do and not do. This is the very big problem in India also. Even Ratlam to hai sahi. Or I
All
think
over India, the same situation.
yeah, or बाकी the special way vaccination there you are specified. It's very nice, actually, very elaborative. You are informed things. So I don't think so. Any query about anything anybody has to query, they can go for it.
Ma'am,
Beta vaccine is it's a must before pregnancy if the patient has taken the rubella, because I have seen rubella positive patient. She delivered baby at say 7 months. She started leaking at 7 months and spontaneous delivery at 7.5 months. The baby survived, but she has a deafness. So definitely rubella is doing notorious thing. And then second pregnancy, before second pregnancy, I give rubella vaccine also, and I give prophylactic MMR also. When
No,
you
but once the patient has had rubella, then there's no need to vaccinate. Only if she does not have immunity, then we have to give vaccine. This is the basic concept.
okay,
So if she has IgG antibodies, we've done a torch test and she has IgG antibodies. It means she's already immunized. She has lots of antibodies to rubella and she does not require the vaccine now. But if she's not immunized, then we have to give her a vaccine, wait for 1 month, and then advise her to become pregnant.
And if she becomes pregnant within 1 month, then of receiving rubella,
Pros and cons. If it is
we
a
have to
very,
explain.
yes, you have to explain. If it is a very precious pregnancy, sometimes they can continue. But
Hmm.
otherwise, we usually think, as an individualized approach, we usually think of termination.
Hmm.
yeah, mostly we are giving after the missed abortion something like that rubella vaccine
Hmm.
to prevent the next pregnancy safer. And we always to say, I used to write down in a paper also, okay, don't get pregnancy within 2 months. But now 1 month is a
One
very
month.
priority, I think. So 1 month it should be. It
The
should. She should
various
complete
guidelines
it
have
in
mentioned 1 month.
yes.
madam, what about influenza vaccine?
Influenza vaccine is to be given in pregnancy.
Should we be giving to each and every female during this COVID era?
Not COVID era is different.
This COVID was also a type of virus infection only, and in this COVID era, everything is different. Otherwise, ideally, we should give it in pregnancy to prevent flu due
Yeah,
to different
swine
types
flu,
of viruses.
influenza,
It is
and
a combination of 4 types of
Yeah,
antigens.
this is a quadrivalent vaccine. Yeah.
Yes,
So we should be giving to each and every female who gets pregnant, and
yes.
should be given in the early pregnancy
It should be given at 27 weeks,
at
20.
27 weeks.
ideally. But
Ideal.
if you think that the flu season is nearby, as soon as the vaccine is released, we need to give it.
Okay.
Every year the strain is different, so every year the vaccine is different. No?
Vaccine is different. The common strains, the common causative viruses are taken up in that vaccine,
Hmm.
and then it is prepared.
Just I ask you one question. In family, if the chickenpox history is positive, chickenpox history is that, or pregnant lady is even if the first child or second child they are having the chickenpox, and mother is supposed to be exposed to them. Can we give the chickenpox vaccine to them?
No, we cannot give chickenpox vaccine. If the mother is exposed, then we need to do an immunoglobulin level, IgG level. If the IgG is substantial, it means she's not going to have infection. She's not going to be affected. But if the IgG is negative, then we have to give her immunoglobulin. Varicella zoster immunoglobulin has to be given. And then as soon as her pregnancy is over, when she after she delivers, that time we have to give her the chickenpox vaccine.
Is the immunoglobulin available?
I have not given it to anyone.
Not that immunoglobulin, what we give hepatitis B positive to the mother, and postpartum we are giving for feeding. Is it different from this one? No, I think so. Immunoglobulin.
Immunoglobulin for varicella zoster is different. Immunoglobulin for hepatitis B is different. That is specifically, even for tetanus also we have an immunoglobulin. That is also different.
Any more questions?
There is one more point which I would like to highlight.
Yeah.
I'm not speaking against anyone, but see, when a woman has had any infection, like when she's had rubella infection, we find out that this woman had an abortion because of rubella. So that means she has immunoglobulins against it and she does not require immunization. If you again give her rubella vaccine, then that is not going to help because already antigen antibody response has taken place. It won't increase her immunity level. So once she's had any infection, antibodies have developed. We can measure the amount of antibodies, IgG we can measure the amount of antibodies. But suppose you give her an injection and then she again, in between she has her pregnancy, then she would need to abort that pregnancy because a high antigen response would cause problems.
So I think so that's why it's, all IVF pregnancy, they are doing the rubella IgG.
Yes, in every pregnancy, ideally IgG levels have to be done.
Yeah.
We
They
cannot do it for our low resource people, but they should be done ideally.
Very nice elaborative lecture, Didi.
Thank you. Thank you for giving me the opportunity.
Welcome, Didi. Dr. Neha, are you there?
Yes, he has gone for the labor room.
Okay. So I thank you, Dr. Anupama Didi, for such an elaborative talk. I also thank Asha Madam to chair this session and all the ROGS member for kind listening. And I would like to have more discussion. If anyone wants to ask some question to Anupama Didi, the floor is still open.
Hello. Am I
Yes,
audible?
Anita.
Yeah,
Yes,
ma'am.
yes.
Ma'am, there is a study which has recently come in intensive care journal saying that the people who are taking influenza vaccine get COVID virus, infection the virulence of COVID decreases in that patients.
Yes,
So
it is same. It is a virus. Like COVID is also a virus. It is like a flu virus.
yeah.
So those who have received influenza vaccine have less chances of having COVID. That is true.
Yeah. So that is what.
Pregnant lady also, we should also take influenza.
Yes, ma'am. We have recently taken, like last month only,
Many people.
we gave to all our family members.
Okay, I think we.
So it should be given at least 1 month before the flu season.
Yeah, the new vaccine had come and we just received it that way.
Yes, that is good. Every year we all should be vaccinated because there are so many viruses in the community. We don't know how they are going to affect us.
Yeah,
At
there is
least
a
some protection,
study.
some antibodies are there.
Every 3 months, no? In USA, they are taking flu shot.
Dr. Joshi, madam, you want to say something?
अरे मेरा आवाज ही गड़बड़ हो रहा है.
नहीं आ रही है मैडम
आ
आवाज.
रही है.
अरे वो लैपटॉप से अब मैं इसमें लिया है, बीच में बिल्कुल गैप हो गया था, अब मैंने इसमें ले लिया.
अभी आपकी आवाज अच्छे से आ रही है मैम.
केवल तुम्हारी सूरत दिख रही है मुझको बस.
दिख रहे हैं मैडम, आप दिख भी रहे हैं और सुनाई भी दे रहा है.
एक्चुअली शायद मैम को सुनाई नहीं आ रहा है.
अच्छा.
वॉल्यूम उतना नहीं होगा.
I think सब questions भी हो गए. So we wind up. Okay, thank you, Didi. Thank you. Thank you, everyone.
Thank you
Thank you,
everyone
ma'am.
for your
Thank
time.
you, madam.
Thank you.
डॉक्टर बंटी मैडम को देख के अच्छा लगा. शी वाज माय
हाँ.
लेक्चरर इन एमजीएम.
बहुत अच्छा लगा उनको देख के.
हाँ. 1968, 68 you were my lecturer, Dr. Bandi madam.
अच्छा.
रोहित मैडम वीडियो करो ना तुम्हारा ऑन. हाँ सुनीता ने.
गुड इवनिंग मैडम.
Good evening, ma'am.
हेलो
गुड
मैडम
इवनिंग
बंटी
सुनीता
को
मैडम.
नमस्ते. बहुत
Hi, Neha.
जी जी
अंजन बोस.
मैडम को देख के अच्छा लगा बहुत दिनों बाद वापस.
हाँ.
उनका
मैडम बहुत बढ़िया सर्जरी करती थी.
मेरे मैडम के लेक्चरर थी मेरे समय, तो लेक्चर्स अटेंड किया.
चलो वेरी नाइस. लेक्चर बहुत अच्छा हुआ.
हाँ बहुत अच्छा.
एक मेरा सजेशन था कि
जी.
जैसे सब डॉक्टर हम लोग प्रोन है सभी चीजों के लिए,
जी.
तो क्यों ना हम अपने जब कोविड खत्म हो जाएगा हम ही लोगों के लिए कोई ऐसा कैंप जैसा रखे कि उस दिन सब लोगों को इम्यूनाइजेशन हो जाए, सोसाइटी वालों को.
गुड
खुद के लिए मीन्स आवर प्रोटेक्शन के लिए अभी जितनी बात हुई है, अदरवाइज
हाँ.
अकेले नहीं करता है कोई. एक आध
मैडम
संडे
इसके लिए तो
आफ्टर कोविड तब हम साथ रह के
हेलो डॉली.
इम्यूनाइजेशन करें.
हाय मनीषा दी, कैसे
हेलो.
हैं
बस ठीक है. क्या
मैडम? कोविड
लेबर रूम में
वैक्सीन
हो?
की बोल रहे? नहीं दीदी अभी नहीं, ओपीडी.
नहीं कोविड नहीं. अभी
कोविड तो वैसे
जैसे
प्रोटोकॉल के
हेपेटाइटिस
तहत
एक.
लगना है.
हाँ नहीं बहुत सी बार होता है कि हमने
नमस्ते मैडम.
हेपेटाइटिस भी लगाया बहुत साल पहले, अभी किसी को पता ही नहीं है कुछ, तो कुछ ऐसे हो तो.
ओके राइट.
राइट मैडम. गुड इवनिंग बंटी
Good
मैडम.
evening,
प्रणाम.
Thank you all to see all of you. I'm very happy to see you all.
सेम
Good
ईयर
evening,
मैडम.
madam.
बहुत अच्छा लगा.
Yeah. अब सबके नाम भी नीचे आ रहे थे.
हाँ.
And I was very glad to see you all from this because okay.
सब आपके स्टूडेंट्स रहे हैं मैडम.
मेरा तो
सभी
एग्जाम लिया है
yeah.
आपने.
Okay, thank you.
मैडम मेरा तो एग्जाम लिया है
लीला,
MS का आपने.
ये लीला तो मेरी क्लास फेलो है, लेकिन उसका डार्क आ रहा है फोटो. फोटो को देख के बहुत अच्छा लगा हमको. चलो अच्छी बात है, ऐसी करा करो. ये बड़ा अच्छा लगता है ये सब नई नई चीजें देखने में अब हमको.
हाँ. जी मैडम.
नहीं डॉक्टर अनुपमा ने बहुत अच्छा इलाबोरेटिव लेक्चर लिया. अनुपमा जी थैंक यू सो मच.
सब नई नई चीजें मेरे को पता लगी. ओके बाय.
अनुपमा मैम गुड इवनिंग.
पैलेस में बैठे हैं. अब कोरोना वायरस का भी आ जाएगा थोड़े दिन में.
हाँ.
उसके बारे में भी बताया जाएगा.
Good evening, ma'am. On behalf of Ratnam ROGS and Gynae Society, I would like to thank all the members for joining in, for participating in this webinar. Special thanks to our guest speaker, Dr. Anupama ma'am, for taking out time and teaching us many new concepts about vaccination. Some things we already knew, some things we were missing out in our practice. And your talk will be very helpful for our practice, ma'am. Thank you so much. Thanks to our chairperson, Dr. Asha Saraf ma'am, for sparing time, for being very interactive in this session. Thank you, everyone. Special thanks to Team Pharmacen.
Thank you, Mr. Arjun. Okay, Didi. Bye-bye. Dr. Anupama Didi. Bye.
Thank you, Anupama ma'am.
You want to discuss something?
Yes, ma'am. Ma'am, we'll wait. Let the guests and the delegates leave.
Manisha. Manisha, you want to discuss some आवाज नहीं आ रही मनीषा।
Yes, madam, just 2 minutes more. पूर्णिमा मैडम हैं क्या? गए?
भोपाल इसी में ना अनम्यूट करके काउंट काउंट कर रही और वहां में चिल्ला रहे हो।
मैडम भी है।
हाँ हाँ।
और ही मैडम भी थे।
मैडम भी है।
हेलो मैडम, सबसे अच्छा लग रहा है देख के।
मैम आप लोग ने
हो
वैक्सीन लिया?
नहीं सुनीता, हमने नहीं लिया, तुम लोगों ने लिया ना?
यस मैम, अभी सब ले रहे हैं। मतलब कहते हैं महाराष्ट्र में भी हमारे जितने फ्रेंड्स हैं उनसे भी बात हुई, इंदौर में भी डॉक्टर अनिल अग्रवाल सर ने हम लोग को रिकमेंड किया था, तो उस समय हम लोग ने सबने लिया। एंड उसका बहुत बड़ा स्टडी आया है। ब्राजील में 95,000 पेशेंट्स जो इन्फ्लुएंजा वैक्सीन ऑलरेडी ले चुके थे, उनको कोरोना हुआ। उनका कोरोना हैड कम एंड गॉन विदाउट एनी काइंड ऑफ कॉम्प्लिकेशन।
ओके।
तो सुनीता, इन्फ्लुएंजा वैक्सीन तो एवरी ईयर वी हैव टू टेक ना?
यस मैम, वी
यू आर टेकिंग डॉली?
हाँ।
लेकिन इस साल हम
अच्छा।
लोग ने नहीं लिया था।
नहीं, मैंने तो लिया था, मतलब मैंने तो अपने रूटीन में लिया था, ये सोचते हुए नहीं लिया था कि कोविड से बचेंगे।
रूटीन में तो वैसे ही ले रहे थे, लेकिन द पीपल हु आर not had been taking since so many years should be taking it for the sake of corona.
ओके, तो कैन वी टेक स्टिल ऑल, अभी भी ले सकते हैं?
यस मैम। और वो कोरोना, आई मीन उसका 3